A very good day, my dear postgraduate students. You will be wondering why I had chosen this topic, thromboelastogram. Obviously, this is a PG university question, a short essay or sometimes a short note. But more important is, it is a purely technical question. Let us see what it contains. Obviously, you people should be making a list of this SNIP, short notes in pathology. Now look at this picture. It is not wrong to consider blood as a connective tissue since it contains a lot of matrix. These were the words of my zoology professor in pre-university class. And see what is over here. I am finding the RBCs entangled in a bundle of fibrin. And since it is within a vessel, we call it a thrombus. Subheadings are subheadings. They will take us to the answer. Always try to have your own convenient list of subheadings for any topic whatsoever. For example, in this I have chosen the historical background, the clinical application, the common tests in coagulation, specimens, uses, the various causes for bleeding, the limitations, so on and so forth. Coming to this, thromboelastogram or graphy is a promising diagnostic modality. So it helps us in diagnosing something. And it is much better than other tests because they are more time consuming and there are variables within them. In 1980, it became a component of transfusions in the Vietnam War. Also, it became important in the liver transplant patients. Obviously, the liver is the helm of any anticoagulant or the clotting factors. These are the other nomenclature. Elastometry is another name that has been given to. As I had been mentioning earlier, blood is not a fluid, but may be considered to be a form of connective tissue since it contains a lot of matrix or fiber. Before we go into any such topic, it will always be better that we maintain the continuity. So in this, these are certain things that will be encouraging to us because we already know this. The coagulation cascade, etc., which I shall be showing you. A very, very, very important diagram. This gives us a clear concept of the coagulation of blood. Though this itself is being outdated is a different modality or an argument. You've got the intrinsic pathway and the extrinsic pathway, and you've got 12, the activated form of it, 12, 12A, 11, 11A, 9, 9A, and then there is a common pathway. 10 is getting converted to 10A. Similarly, simultaneously, there is an extrinsic pathway also from which you get the factor 7A and the tissue factors. Ultimately, you find that there is the conversion of prothrombin to thrombin, fibrinogen to fibrin. Here are clot ends. At the same time, you find that there is the factor 13A, which makes it more stable. You need a stable clot whatsoever. Now, there are many functions of it. You people can go through this at a later date. Let us not go into this very complicated something like a physics or mechanical engineering, which I am averse to. Developed and described by Dr. Helmut R.A.T.S at the University of Heidelberg in Germany. So this is something. Look at this, a very sturdy equipment over here, and then the various diagrams and the graphs that are derived from them. There are certain common tests for blood coagulation, all of you are aware of. They may be the prothrombin time, the international normalized ratio INR, activated partial thromboplastin time, platelet count, fibrinogen concentration, D-dimer. Of late, it has become very important, activated clotting time, and the whole blood bleeding time, probably a little outdated. So there is an entire panel of investigations. And coming to it, there will be, to diagnose coagulopathy, you will have to monitor the anticoagulation treatment that has been given to the patient. Any of the bleeding episodes and the type of bleeding. Factor analysis. Of course, this is important. Once we localize on the extrinsic or the intrinsic pathway, and then we try to analyze each of those factors, that becomes a factor assay. So there is a factor 5, then protein C or S, antithrombin. So these are all certain things. Cardiolipin antibodies. These are again to be measured. Prothrombin gene mutation of late. So you find that there is an entire long panel and the turnaround time for all these will be extremely long. Probably the patient or the surgeon will be very patient to receive our results. And added on to it, whether it is an arterial or a venous thrombus, is some other context. Coming to bleeding per se. What is bleeding? From an intact blood vessel, you find that the blood oozes out. It can be because of a major trauma or surgery. It can be medical complications. Example, rupture of an aorta. No surgery per se at all. Coagulation factor deficiency, wherein there is spontaneous bleeding. Hemophilia being the classical example. A or B. Von Willebrand's disease, again. Whether the patient is on anticoagulants and antiplatelet treatment. So these also can be leading to. And any of the loss of the clotting factors because of bleeding itself, or because of dialysis, or because of renal problems, you find that there can be a loss of the clotting factors. So it is an entire list. The problem is we will have to localize on the exact point and plug it. So what are the disadvantages with all the other tests? This will appear a little out of context, but it will help us greatly in answering question on your approach to bleeding disorders. Long turnaround time of the conventional test, and they do not provide a complete picture of the hemostasis. Platelet concentration does not reflect upon the platelet function. And similarly, the fibrinolytic activity is not being measured. There are antiplatelet agents such as uremic drugs, and individual clotting factors are also not being routinely assessed. So these are certain things. Factor 13, platelet function, and fibrinolytic activity are all not being routinely assessed. These will be some of the disadvantages of the routine tests. Now, what sample do you get? So this is technical. If you want, you people can remember. Otherwise, you please remember that there is a venipuncture from which you get the blood, which is in a plastic vial in 3.2% buffered sodium citrate. And the ratio is 1:9. Mix it. Always sodium citrate, no? It can come in a case of ESR also. You get a trisodium citrate where the ratio is 1:4. Here it is 1:9. Please be very careful. One of your examiners will definitely be a pundit in the blood banking. So the clotted sample cannot be assessed, and non-clotted samples can be kept at room temperature for a period of 2 hours, not beyond that. Non-citrated blood, you will have to use it immediately. All this is citrated, sometimes non-citrated, you will have to use it immediately. And the volume required is this. There are certain modifications of thromboelastography. One is the classical one, which we are going to describe. The other ones can be rapid TEG. rotational thromboelastography or thromboelastometry. That is why it is called as ROTEM, rotational thromboelastometry. Then there is also a platelet mapping assay. So these are some variations which we can mention in the answer. 1, 2, 3, 4, not very difficult. What is the clinical significance? It is goal-oriented and individualized care is being given. It is a global assessment in the sense a wholesome approach to the problem is there. So it can be on the coagulation cascade, platelet function, as well as fibrinolysis. Rapid real-time bedside test. Where is the point of care? So it can be done by the bedside itself. Coagulopathic bleeding. Guiding transfusion therapy. Also, sometimes for a transfusion, this might be needed. Decreased use of the blood products. Once we know exactly what is wrong, that particular component alone can be given. So avoiding a whole blood transfusion. Detecting the dynamic changes in the blood coagulation. That will be shown to you in the form of a graph and predict the clinical efficiency of the therapeutic agents. So this will be the clinical significance or the advantages of this particular test. And for whom is it recommended? Patients with ongoing bleeding, where optimal care is required, cost effective, and you need not do all the tests as such, monitoring antithrombotic activity. So these are some of the things. So this again, there is one. Always you find that there is a balance between bleeding and thrombosis. And finally, you find that there is a fibrinolysis also that is happening. Otherwise, our blood will be filled with clot. Ultimately, you find that the plasmin, the fibrin, it gets broken down, plasminogen. This is the hero of today's class, the ROTEM, rotational thromboelastometry. So you find that there is something called, say, a plastic sensor is over here. There is a cuvette with blood that is over here. The red color is the blood in a container. And what happens is once there is a motion, you find that fibrin strands start coming in. So in the initial stage, it will be more towards the periphery, but later on they become more adhesive towards the central region. So this is called as a heated curette hold. And what happens? There is a rotation and physics, etc. This is being absorbed by means of a light source, and there is a detector which can deliver the details onto a computer. So this is as simple as all that you have to do is fill in this container with blood. See what is happening over here. Again, it's a repetition. So you find that there are some charges, the curette is over there. There is a pin, it is important. And a transducer which will be transmitting the pressure or the vibration. There is a whole blood. Obviously, when there is some kind of a motion, the fibrin formation sets in. And this is called the oscillating cup. There are some variations, we will not be going into it. But this kind of a diagram you people can draw very well in your examinations. So this is the text of it, you people can write. So you find that it is a non-invasive technique and it quantitatively measures. It is an in vitro test. And the design is a thromboelastograph that you are going to see, something like a ECG. There will be two chambers which I will be showing you, and that sampling and the measurement errors can be avoided. Look at this. This is extremely important. It will look a little complicated, but see how well the author has made it simple for us. There are two chambers, one for coagulation, another for fibrinolysis. And you find that there are various things. There are two stages again, coagulation and fibrinolysis, and two compartments are over here. R is for the reaction time. So it is the initial time taken for the clot to form. And K is for the kinetics. For this to attain some kind of firmness. The angle, you find that always when there is a motion, there is a particular angle that is getting formed. This varies from disorder to disorder or from condition to condition. And MA is the maximum amplitude over here, and here the lysis is sitting in. And there is a percentage which can be measured. Ultimately, there is a lysis or a breakdown. A beautiful and a simple diagram, but this is a must for us. And on reporting, there will be a normal thromboelastogram. Multiple parameters can be measured. I'll be showing you a text on it. And the coagulation index, which can be measured with what the manufacturer had given. This is what it is. Thromboelastogram. You find that in one, the various components are there. What we had already seen. The R time or the reaction time, kinetics, the alpha angle, maximum amplitude, and lysis, the time at which it starts, and the definition of it. For example, R time means starting of fibrin clot. Then the lapse time. The alpha angle will be the speed of fibrin deposition. And MA is the highest vertical amplitude and percentage amplitude reduction or the lysis. And this will be the normal values. The problem in this will be there can be the clotting factors. So fibrinogen, platelets, and excess fibrinolysis. So these will have to be monitored. And the treatment for any of these disorders will be either a fresh frozen plasma or a cryoprecipitate or platelets are DDAVP and antifibrinolytics. Courtesy rebel.com for this beautiful table. So this will give us an idea. At least I would like you people to see the components and what are all the things that can be measured. Look at this. This is a normal one. You find that the thromboelastogram of you and me may be looking more or less like a cylinder. But when anticoagulants are there, there is a more acute angle that is getting formed. Sometimes when there are platelet blockers, it is somewhat via media between these. And in fibrinolysis setting in early, you find it becomes more conical. Here it is cylindrical, it becomes conical. That means within a short time, there is a fibrinolysis. Hypercoagulation, you find that it gets prolonged. There is no light opposite of this. And DIC again. And there can be the various stages of it which can be measured. So these are all some of the diagrams, and this is exactly what will be depicted in the report. Again, a replication of the same. You find this is a normal one that you had seen. In you and me, with anticoagulants, what happens? In platelet blockers, what happens? Fibrinolysis. You find that there is an early tapering. And hypercoagulation, you find it becomes broad and cylindrical. DAC, a combination of both, and then finally a hypercoagulable stage. So this is the one. So the various angles, it has got various implications. We will not be going into it, but then you'll be able to measure the hypercoagulable, the normal, hypocoagulable, the platelet function, net platelet function, and the therapeutic level. So look at the number of parameters you people can measure by means of this single test. And of course, it is highly reliable thanks to the source of chemonetics, UK. So this is an important diagram. Please do draw it. There is a cup. Okay, it contains the blood. And there is a pin that is then, there is a rotation in motion that is there, a movement. So that will be a generation of fibrin. And there will be a clot that is starting. Initially, it will be more towards the periphery, but with the spinning motion, it gets adhered towards the center. And then you find that the blood gets clotted around the pin. This is a detection pin and the output can be measured. So this is the instrument as simple as it there, almost like your Sysmex or a hemocytometer. These things we have already seen, and there's a text of it. I would like you people to write this exactly. And there's a simple line diagram of the same thing. Thromboelastogram, it is a graphical image. Elastogram or elastograph means it is a graphical image of the amplitude of movement in the pin. It is attached to an analytical software, and it measures the functional ability of the blood to form a hemostatic block. And it has been replaced by other techniques such as resonance, or it can be measured by LED illumination. So these are certain variations which I had mentioned. So this is somewhat an analogy that the author had given, probably a different version. So this is the reference of it. So look at the various things in which you people can hold a drink of it and sip it and enjoy the thromboelastogram. Blood is thicker than water, but loyalty is thicker than blood. I thank you for your patient listening. Please do by heart. This topic is no longer difficult for us.